Hi, this is Sandy Zhang Nunes, and I run an oculofacial practice at an academic center. And thanks to Mike Migliori and the other panelists for hosting this with me. I wanted to start with why this is important. We want to protect our patients, ourselves, and colleagues. And unfortunately, more than 9,000 U.S. healthcare workers have been infected with coronavirus, and you probably know some of them. And over 100 doctors and nurses have died combating the virus. Here's Li Wenlei. And a study looked at the transmissibility potential of the SARS-CoV virus, and in isolation rooms of 13 patients, viral RNA was found on all the toilets, sinks, windowsills, and in the ambient air. And a study out of NIH found that the stability of the virus was present even 3 hours in the air when there's no ventilation. This is when they mimicked a cough or a sneeze. It was found 4 hours on copper surfaces, 24 hours on cardboard, and 2 to 3 days still present on plastics and stainless steels. When we look at aerosol potential, there's a study done a while ago looking at 50 surgeries from ENT, GYN, plastic surgery, and ortho, measured tens of thousands of different particle sizes. And the finding from that was that power tools produce the highest aerosolized load, and primary aerosol generators outside of the stereo zone were actually laser or electrocautery and electroscalpels. So there are several published reports and recent news that suggest SARS-CoV-2 can cause conjunctivitis via aerosols or hand-eye contact, and this is a nice summary on the AAO website regarding that. And you probably have all heard the report coming out of Wuhan, where all 14 people who entered an OR during an endoscopic pituitary surgery became infected. And these are people who are wearing surgical masks. And ENTs and ophthalmologists who passed in China from SARS-CoV-2 were overly represented in the healthcare workers who passed from the virus, unfortunately. And this may be because there's a higher viral load in the nasal passageway, and also that endoscopic surgery aerosolizes virus particles, which then may stay in the air for at least 3 hours. So some of the procedural concerns we have as oculoplastic surgeons is that we do a lot of MAC surgeries, and there's a possibility that when we are injecting local, the patient is snowed from the block, we might have to turn up the nasal cannula to 6 liters even or above, and they often sneeze with local injection, that this might be a part of the surgery that may cause aerosolization, and even nasal cannula at lower flow can have possible aerosolization as well. And of course, we know that intubation and extubation are aerosolizing procedures, and endoscopy, which we do in clinic. And there's some question of maybe even irrigation of the lacrimal system might be aerosolizing, especially if the patient coughs or needs to spit stuff out from the procedure. And one issue we have to keep in mind is sometimes we'll order COVID tests maybe before all the surgeries or any of these aerosolizing procedures. However, the sensitivity of the test is not great, and there are reports that it may be only 70% sensitive with the RT-PCR. And in this study, in patients that were actually really sick with pneumonia, even then, only 83% were positive. And these are patients who had pneumonia findings, and later they were determined to be COVID positive, and the initial test was negative. So what are the different PPE available to us, and what are the differences? There's the N95 and the surgical mask. N95s have greater filtration efficiency and are supposed to have a complete seal. Surgical masks do not have a complete seal. And how do we look at the filtration efficiencies? Well, bacterial and viruses are usually carried on droplets, and they look at the 3-micron droplets. And even though bacteria is 0.3 microns and viruses are 0.03 microns or less, The idea is that they are still transmitted through droplets, so that's the filtration efficiency is only looking at the droplet size. However, NIOSH requires submicron sodium chloride particle testing, which is only 0.1 microns, and N95s have that greater submicron particle filtration efficiency. And there's lots of different N95s. As you see, there's the more form-fitting collapsible ones, such as the Halyard or Kimberly-Clark ones. There's the more cup ones that are the green type, and there are also masks that have valves. And the XL valves are actually not safe to use for your patients because your breath is not cleared or filtered when it comes out. And so actually areas that require masks, if there's an XL valve, those masks are not allowed because they need to actually have your exhale blocked. And then there's also an N95 versus KN95. The nice thing is that 3M has compared these different types of respiratory devices, and the N95 and KN95, the proper ones, are supposed to have similar filtration capabilities. The FFP2 is European, there's also the Korean ones, and this is a nice chart with the link down there if you want to look at the 3M comparisons of the different types of respirators. However, you do have to be wary of fake KN95s in particular. And with any mask, if you smell anything through the mask, you do not have a good seal and good filtration. I wore my N95 during a recent orbital decompression, an orbital lateral wall window surgery, and when sawing the bone, I smelled a lot of smoke, and that's when I realized my N95 did not have a good seal on me, because I asked the other people who were in the room, and if they had the N95, they could not smell it. So then I got fit tested. And then Mitesh Kapadia in the chat actually put this link down to share that there were unfortunately a lot of KN95s that were imported that did not have the filtration efficiency that they should have. N95s. And fit testing. Okay, so that's the most important part that I wanted to emphasize, is that you might have an N95, but if you don't have a good seal, you're not adequately protected. And I didn't realize how important it was before because I could always taste whatever that saccharin bitter solution that they gave, but I didn't really make a big deal of it, and I said, okay, sure, whatever. And then now I realize we're in the middle of a pandemic. It's probably important to report that I don't actually have a good seal, and because of that, they fit me with different masks, and I could pretty much taste with all of them. I'm required to use a capper or a papper in situations where an N95 is needed. So, and you can test other respiratory devices that are even homemade or 3D printed to see if they also have a good seal this way. One other key thing is that the aerosols can be transmitted through droplets to the eyes, so we want to make sure we have adequate eye protection. The center one is what I use in clinic, and I have a more sealed one on the cases where I am going to have an aerosolizing procedure or at least a lot of aerosols. And you can also wear a face mask. Here I'm being a little bit redundant here, but I think it doesn't hurt to always have more protection if you have it available to you. One tip that I want to give you in wearing these eye protection is to have some anti-fog that we usually use for endoscopy and put on the inside of your glasses, goggles, or face shield, and that really helps with not getting that fogging problem that you'll definitely get anytime you're doing some sort of procedure with these and get warm. So what's the difference between a PAPR and an N95? Okay, so a PAPR is a powered air purifying respirator. And the PAPRs reduce risk of exposure even more than the N95. And the way they judge that is by using an assigned protection factor. So an N95 has an APF of 10, which means that the exposure risk is reduced by 10 when wearing an N95 versus nothing. A loose-fitting PAPR will reduce your exposure by a factor of 25, but a tight-fitting PAPR will reduce your exposure by 1,000. So it's multiple orders of magnitude better to have a tight-fitting PAPR versus N95 in a situation where there's a lot of aerosols. So how does a PAPR work? There's lots of different types of PAPRs on the market. Unfortunately, they're all in short supply now. But basically, there's a battery power pack that powers basically a fan blowing into the mask, so that you have positive air always coming out. So and there's a filter, so you're only breathing in the filtered air. One thing to remember is that when you breathe out, that air is not filtered out towards the patient. So you still need to wear a mask to protect the patient when wearing a PAPR. So the limitations, as I mentioned, is that they are limited in number, unfortunately. We just don't have enough of them, which is why they're not able to be more widely used. They can be bulky, and if you're wearing one of the ones that go over the shoulder, can contaminate the sterile field. It's hard to use a headlight with them. You can't really use it with the microscope. This is an example of the capper that we have at our institute, just actually a continuous air purifying respirator. And that the air comes in through the helmet. And it's actually really comfortable. My ears felt a little cold after a while, but you see that I can wear loops and a headlight underneath it really well, and I felt like it was great visualization. I didn't have any trouble maneuvering. This is very lightweight, really comfortable. They're a dream to have. If you can get your hands on one of these, that would be ideal. I wish I could personally have one, but we have to check these out. And the front shields and this plastic wrap are disposable. So the one concern is running out of the plastic shields, because the actual the helmet can be just wiped down and sterilized. So what if you don't have enough PAPRs? One option are these full face snorkel masks. And what I'm showing here on the right here with the pink mask is all you need is a 3D printed adapter and then a filter that the hospital provides. It's basically like a HEPA filter. And this is supposed to filter all the air. The air goes in when you breathe in, and then when you exhale, it comes out the bottom and it comes around back up towards the top and out the filter again. Again, you can overheat in it, so put some anti-fog on the eye area, and then you won't have a problem. The nice thing with these is you have a little seal so that the breath usually doesn't fog up to above, which is designed well because it was intended for snorkeling. So on the left, I'm showing that you can 3D print an adapter as well, where you can attach an indirect light, and then you see the little green thing that's stuck to the front of the mask. That's actually an adapter to attach a headlight that you can just take off your loops and apply there as well. So there's different modifications that can be done by this. We can even actually add a fan to it to make it more comfortable and make it more like a PAPR. And there's efforts to try to see if there's add loops to that too for people that need them. So with these devices, there's challenges. Obviously, working with a microscope. With a PAPR on the left here, it's pretty much impossible to get a reasonable view because your field of view is just too small. With the snorkel mask, it's like wearing glasses that are a little bit too far from your face. Your field of view is still there, but it's just more constricted. It's sort of like operating with 50% of tunnel vision. So it's still doable if you keep everything in the center focused, but probably takes a little bit of practice. Ideally, you have a heads-up device that doesn't require looking into the oculars. There are other options to consider as well. There's the N100s, which are going to be more difficult to breathe in. There's these silicone N100s that are respirators. For me, it doesn't fit my face, unfortunately. And there's all these reusable ones that can be constructed out of just pieces that are comment on the anesthesia tray. So this Children's Hospital Surgical Innovation Fellowship was able to describe how to use those. Interestingly, I talked to my hospital group that's working on innovative options as well, and they told me the best material to filter is actually the surgical wrapping the wrapping around our surgical instruments for sterilization. So that actually is a great filter, and it's actually a polypropylene material. And I found recently that a CRNA and her husband have started creating these 5-layer masks using this polypropylene filter. So supposedly that has actually pretty good filtration that might be more comfortable than in N95. So something to consider. In the chat thread, some other members made recommendations, such as Eva Cho for 3D Agents of S.H.I.E.L.D., who provide free face shields. You can request that on the website. Vivian Scheidler also recommended EnvoMask, which is a reusable N95 with a replaceable filter. These are designed for industrial purposes, however, and so there is an exhale valve that you have to keep in mind. So you would need to wear a mask on top of that to protect the patients as well. And keep in mind all these other options are may or may not be accepted at the hospital that you go to, but you could consider using them in your own private office. For example, we'll be using the full face snorkel masks for when I'm going to do endoscopy in the clinic, and that's a way to utilize these other resources. There's not enough PAPRs, or if you have a poor fit with your N95. Other options to consider. This is just a tongue-in-cheek graphic to compare the 42,000 healthcare workers who went to help in Wuhan, who supposedly did not get any infection because they were dressed up in hazmat and completely covered like this. But the idea is that if you are able to afford additional protection, why not? As it decreases the transmission even. So Holly Chang proposed some questions that we could address during our session, such as, are you planning to provide masks to patients who do not have their own? In our case, we do provide masks to all the patients, because all patients have to wear masks as well as all staff in our practice. Or at an academic place, we source our surgical masks through the hospital, as well as N95s or KN95s. Anyone using a barrier device for office surgery, that's something to consider, maybe for doing laser procedures. We already discussed the prototype or instructions for making your own. And there are also questions about patient testing and the availability of insurance coverage. I believe most states do mandate COVID testing to be covered by insurance. However, we don't know for sure if that applies to asymptomatic patients or not everywhere. A lot of hospitals and universities, including mine, do mandate pre-op testing 2 to 3 days prior. Whether that's totally reliable or not is another question, and how to make that available. We, for example, have a drive-by testing tent that the patients can go and just get swabbed in and out in their car. And I think most places are making that available. And modifications for in-office visits. There are questions on whether there should be temperature screening and how to phase in reopening, spacing appointments apart. Should we just start with, for aesthetics, just consults and Botox, and then biopsies? How long before doing lower face procedures where the patients would have to take off their mask? And we discussed the cannulicular irrigation and endoscopy questions already. And then modifications for surgery, how much aerosolization does occur with MAC, and should surgical staff stay out of the OR before and after intubation? In our case, they are required to, if you don't have an N95, you should not be in the OR at least 30 minutes after intubation is complete. And Holly Chang asked if patients or cosmetic patients would be charged for that extra time. In high-risk sinus cases, do we need to wait 3 hours between cases because of aerosols? I think some hospitals are doing that and others are not. And Scott Goldstein is going to go over all the guidelines, but in regards to PPE, the ASOPR's guidelines do recommend avoiding cases with high risk of viral aerosolization if possible, SARS-CoV testing prior to surgery if possible, and then only personnel required for intubation and extubation should be present. These are PPE recommendations from the American College of Surgeons. You can go to their website to look, but basically they group by aerosol generating procedures, which include sinus procedures, and those require PAPR or N95 respirator plus face shield or eye goggles. And then there's the controversial COVID-19 negative, where people are actually leaning more towards still using the N95 since we don't know how reliable that testing is. So there's actually a really nice paper that describes an OR protocol used in Singapore where 0 of their healthcare workers were thought to have been infected within the healthcare system. Basically, they have a negative pressure anteroom, keep the same OR for the COVID cases. There's a known airflow pattern in the room. Everything is ready ahead of time. They secure the airway using the highest chance of first-time success, so with video. And then any patient transfers are also with full PPE. And these are some other good recommendations. They do wear PAPRs during induction and reversal of anesthesia, minimum an hour between turnovers, any airway procedures using PAPR as well. And what was also interesting is that they use a hydrogen peroxide vaporizer to clean the rooms and re-sterilize, decontaminate the rooms. And then there are recommendations from head and neck surgeons that say if SARS-CoV testing is positive, you should weigh the necessity of the surgery again or delay if possible. And then the high-risk procedures are nasal mucosal, oral pharyngeal, pulmonary, and use of microdebriders and drills are going to increase the aerosolization. Patients also need to have appropriate PPE, which means they should also have masks regardless of SARS-CoV status. And then finally, these are the guidelines at our center. Our patients all do get testing 2 to 3 days prior as of now, and hopefully same day eventually. There is a dedicated team that does intubation and extubation, and anyone not wearing an N95 must wait 30 minutes prior to entering the OR. And there's a terminal clean that follows the TB protocol. And for high-risk procedures on patients who are test negative, right now N95 and face shield goggles are sufficient. But again, you have to make sure you fit test for the N95 and make sure it's adequate protection. And the Singaporean paper recommended everybody showering right after working with a COVID positive patient, but that's not currently a standard of care, I believe. And these are some other guidelines and recommendations of the different types of PPE recommended. And for ophthalmology, for a COVID positive patient, they also recommend a PAPR. And these are, again, for high-risk surgery for COVID positive or just a patient of interest for COVID. And these are guidelines that Rao Chandri provided that were helpful from Nebraska. They're similar, and they kind of break it up between standard PPE and augmented COVID PPE, and they also break it up into ultra high-risk surgeries, which are the ones involving the sinus and the glottis, and the augmented COVID PPE should be used ideally. Okay, and then right now we have to rewear the mask. So what's happening on our institution right now is everybody is now going to be issued one N95 per faculty or staff. So everybody gets it, including the front desk staff members. They all get an N95 that they could wear for a week. So the extended use means you could wear for 8 hours, and then if you protect it with another mask on top, you could rewear them as well. Some people have talked about sterilizing them with UV. There's also a way, Stanford put out a paper, I believe, about using, baking them in an oven, 170 degrees, whatever the lowest setting in your oven is, for about 30 minutes would also work. There's also a protocol to just wait 72 hours and rewear it and alternate the mask that you have. This is the reuse. Extended use. Extended use is better over reusing and changing with every patient. For me, I just wear the same mask all day. I don't even bother to take it off to eat because it is just another way to another point of contact and risk. So obviously, we're all trained to wash our hands before and after donning, and wash our hands before and after doffing our protective gear as well. Okay. So those are the main things, and for the major risk actually that we have to keep in mind is not just from aerosols, but contact transmission from touching surfaces contaminated, including the masks. So and to keep in mind that we often touch our faces and eyes maybe even 25 times a day if you're not thinking about it. So that's why it's so important to wash your hands. And contact transmission with others by direct or indirect, meaning just touching contaminating surface, is probably like a fomite is probably a way that we get transmission. So when the surgery is over, remember that viral contamination of surfaces, again, plays a significant role in disease transmission. Hand sanitize, wash hands, even maybe consider using disposable gloves even for an ATM, vending machines, gasoline pumps. We want to clean our cell phones frequently, remove our clothes and maybe wash them upon arrival at home. I disrobe and put everything in a garbage bag in the garage, and have a towel, a dirty towel ready for me to walk in with, and frequent hand washing, as we all know. And we should clean all hard surfaces with disinfectant. Fortunately, this is a virus that responds really well to alcohol, unlike adenovirus. And if you are actually called to work on a COVID ward, hopefully none of us are at risk of that anymore, you can consider asking for hotel accommodations, and each center should have that available. Thank you very much. Hope you learned something. And then the rest of this talk is recorded with all the discussion as well. And we'll also upload the chat thread starting from the halfway point. So the first half I forgot to record, which is why I'm presenting it separately here. And the rest of the half will be online. Thanks for listening.